Wisconsin Upper Michigan DHQ. So we're going to get going with our webinar in just a second. Just a few kind of announcement type of things. Thanks to everyone for coming, even with a little bit of a date change, and apologize for the confusion. In a minute, I'll tell you how we can kind of clear that up in the future. For those of you who are attending for the first time, there is an ability to ask questions. If you type them into the question box or the chat box and send it to, I don't know, just type it into the question box, that's easily. And then I will monitor those while Deb is presenting, and then I'll interrupt if those are necessary, or we'll do them at the end, whatever is most appropriate. Additionally, we will be recording this, and I will send a link to all of the attendees next week, hopefully Monday or Tuesday, as well as any attachments or slides from the presentation that you'll be able to review that or share with additional staff. We'll also have it uploaded onto our Pathway of Hope Lotus Notes database for those of you who know how to get into that, or if you need assistance, I'm sure there's someone who can assist you with that as well. And then also in that email, there will be a link to a form you can fill out on the web if you want to be added to the direct email list for these webinars, so that you don't have to have them forwarded through your social services director or something like that. You'll get those directly from me regarding the registration and any changes. So without further ado, we'll go ahead and get started. I'll introduce Deb DuFour, who has presented for us in the past and does a great job. She is a program manager with Washington County Human Services here in Wisconsin, and she's going to be talking a little bit about mental health issues. Again, if you have questions, just type them in the box, and we'll try and get to those as appropriate. So there you go, Deb.
All right, thanks, Rachel. Well, good morning to everyone, and I appreciate you accommodating the time or the day change. I kind of goofed with my schedule and ended up that I was at a training yesterday, so I'm glad that I can be here this morning and give you some basic information about mental health issues. Just a little bit about me. I have about 25 or more years of experience in the behavioral health field. I have a master's degree in organizational leadership and quality. I am a certified substance abuse counselor and an independent clinical supervisor here in Wisconsin. I've worked in the alcohol and other drug abuse outpatient setting as the alcohol drug abuse case manager for Washington County for about 15 years, and as part of a multidisciplinary behavioral health inpatient program. I currently manage our 24/7 mobile crisis intervention team. We have a lot of skills in working with people, developing program guidelines, suicide assessment, and safety planning. And I've served as a member of the Consumer Survivors Subcommittee of the National Suicide Prevention Lifeline, also part of the Wisconsin Crisis Network, and I have worked with Prevent Suicide Wisconsin. So we're going to start with just some basics about mental health issues. And I want to just kind of lead off with a little bit of a disclaimer by saying that I'm just going to provide a brief overview regarding some of the types of mental disorders that you may encounter being in a caregiving role, and that very recently the DSM-5, or the Diagnostic Statistical Manual, 5th edition, has been published, and a lot of these disorders have been renamed or reclassified, and so I'm going to be kind of basing mine on the previous version, the DSM-4, and then the new one will be coming out, and there are a lot of trainings around that people are attending at this point in time to learn about the new DSM-5. The DSM-5 is, again, it's a kind of a Bible in the mental health field. It's what therapists, psychiatrists, psychologists use to review criteria and actually place a diagnosis on a patient. And so it's kind of the be-all and end-all of disorders. And it's typically not something that people, even in my role, are that familiar with. It's typically more master's level therapists, psychologists, and psychiatrists that rely on this book. There are some other books. One is called a Physician's Desk Reference, or a PDR, which is a huge reference book that most doctors and pharmacists are very familiar with, and it has a lot of information about all of the different drugs, interactions, things that could happen to people if they are prescribed these medications. I like to refer to a nursing drug reference book. It's usually it's written in much more layperson English, and can be purchased most commonly at a bookstore at a technical college that has a nursing program. And this book has pictures of medications, all of the different kinds of side effects, interactions with other medications, and it's a good handy book to have available if you're able to have it, like just have one in the office that people can go and look to and make reference to. It's a really helpful tool. I'm going to start out by talking a little bit about what we would call adjustment disorders. And this is a reaction to a life event or a change in circumstance. It's typically some kind of a stressor, perhaps a job loss, a death, relationship loss, and it's often a very normal response to that type of stressor. Sometimes it's such a strong response that it does interfere with functioning, perhaps with some sleep or appetite issues, and so it may warrant having a therapist to talk to about it, or to at least have a doctor recognize that if there are some sleep issues, maybe a short-term trial on a sleep med might just help kind of get the person back into sync. This is a disorder that may resolve on its own, or it might need some kind of mild intervention. Then we have a whole class of disorders that we call mood disorders, and these typically include things like depression, bipolar disorder, trauma, anxiety disorders like obsessive-compulsive disorder, panic disorder, or PTSD, post-traumatic stress disorder. These typically have a little bit more impact on functioning. Again, they can interfere with sleep, with appetite, with normal routine, normal functioning. Things like bipolar disorder, people can be very depressed to the point that they aren't able to get out of bed, or they can be manic, where they have lots of energy, they go for days, perhaps without sleeping, they often have very pressured speech, they engage in maybe excessive spending or hypersexual activity, and so it's pretty apparent when people are in a manic state that they need to have some kind of intervention. Trauma is something that we are learning more and more about every day, and there have been a lot of recent studies that talk about brain development and trauma, and we're learning that if a child experiences some sort of trauma in their young life, that oftentimes their brain can stop growing normally or responding normally, and so we actually do see some brain changes, and as they become adults, we are able to kind of identify some things that perhaps are different for them in terms of their mood and behavior because of a childhood trauma. So it's kind of an up-and-coming new area that people are studying quite rigorously, and we're realizing that trauma has a tremendous impact on a person's brain development and their personality and behavior development. We also have the whole area of anxiety disorders, which can range from being a little bit nervous to having obsessive-compulsive disorders, panic disorders, or again the post-traumatic stress or PTSD disorders. Then we have a group of disorders that are identified as thought disorders, and these usually include things like schizophrenia or delusional disorders. With schizophrenia, we find that individuals have thoughts that are often not based in reality. They may have intrusive or paranoid thoughts. They may have persecutory thoughts, and they may also be experiencing auditory or visual hallucinations. More commonly, the auditory hallucinations are voices, and they frequently are unpleasant voices. They hear noises in their head, things that are disturbing and distracting. Typically the voices are rude or just saying unpleasant things. And an extreme is where they would actually feel command hallucinations, where there are voices telling them to do things, like telling them to kill themselves or telling them to kill someone else. And that's a pretty extreme symptom, but it is a symptom of schizophrenia. Delusional disorders are where people have very strong beliefs in irrational or untrue thoughts. They may believe that the government has implanted something in their brain, and so all of their thoughts are transmitted to the White House. Or they may believe that their landlord has implanted cameras in their apartment and they can see everything that they do. Or so these are very disturbing kinds of beliefs, but they are very real to the person that's experiencing them, and there's probably no amount of argument that you could provide for this person to get them to change their belief in this. This is something that they just totally and wholly believe is true. Now, with treatment options in terms of schizophrenia, medication can help reduce the voices and kind of ease the feelings of paranoia. But with delusional disorders, it's a little bit more tricky, and medications usually do not take those kind of beliefs away from someone. And then, of course, there's a whole area of substance abuse disorders, mainly alcohol, illicit drugs, and most recently we're seeing just a huge rash of prescription drug abuse in the terms of OxyContin, Vicodin, also leading to heroin use. And this is, we see symptoms of people not being able to have jobs. They engage in illegal activities to be able to obtain their medication or drugs. There's a whole host of other medical conditions that can happen because of their drug use. So it impacts individuals' lives in tremendous ways, and then, of course, impacts the family as well. Then there's a range of disorders that have been in the DSM-IV called personality disorders. And these are typically a range of personality or character traits that kind of describe or enable the person's functioning. And sometimes these traits are very difficult for us to deal with in another person. But one of the things to try to help us deal with that is to try to remember that these traits are adaptations that allow the individual to cope with emotional distress. For instance, if a child has grown up in a very physically abusive family, they may, as an adult, grow up not trusting people, being manipulative, just a whole host of, being very dependent on other people for relationships and for satisfying their needs. And while they are difficult and they interfere with the person's functioning, they are adaptations that person has developed that allowed them to cope and survive through whatever the trauma or the abuse was that they experienced previously. There is a classification that's called severe and persistent mental illness, or SPMI. And this is a mental illness that is described as being severe in degree and persistent in duration, that causes a substantial diminished level of functioning in the primary aspects of daily living and an inability to cope with the ordinary demands of life that may lead to an inability to maintain stable adjustment and independent functioning without long-term treatment and support, and that it may be of lifelong duration. This is typically people that have schizophrenia or bipolar disorder, but there certainly are a number of people that have other disorders that can be classified under this description. And these people are typically the folks that we see that may be on Social Security disability because of their mental illness. They have very, very difficult time maintaining jobs, relationships with others. They have issues with budgeting or keeping their finances in order, and oftentimes need very intensive support so that they can continue to live in the community versus living in some kind of group setting or institution. And a lot of times we'll see these people being participating in what we call a community support program, or a CSP program, where they have access to a psychiatrist, nursing staff, case management staff, therapy staff, and they may be involved in that program for a good majority of their adult life. Just a quick overview of some of the psychiatric medications that we see frequently. The first category are the antidepressants, and most commonly now we refer to what are called SSRIs. They are selective serotonin reuptake inhibitors, and these allow the serotonin to kind of stay floating in the brain a little bit, and they're often used for depression, for anxiety disorders, some obsessive-compulsive disorders. Typically, the label names were Prozac, Zoloft, Paxil, Celexa, Cymbalta. Now some of them are fluoxetine, sertraline. These are a group of antidepressants that have very low side effects and very low risk in terms of abuse or overdose. So they've really kind of broadened the ability for folks that have the appropriate kind of psychiatric disorders to have some great benefit and improvement in their treatment. Some older antidepressant medications were the tricyclic medications, Elavil, amitriptyline, nortriptyline, Pamelor. These are medications that are less frequently used today because there is a potential for overdose. And so psychiatrists are, of course, less comfortable prescribing them to people who are depressed and may actually have thoughts of suicide throughout their life. So these are less used in treatment of depression, although they are used in some settings for migraines and some kind of pain relief. But that's usually under the care of a pain management doctor. And then there are the MAO inhibitors, monoamine oxidase inhibitors. And these are, again, an old class of antidepressant drugs. One of the familiar ones that was used a lot in the past is called Nardil. And these are medications that are typically tried as a last resort because there are some dietary restrictions that people have to follow when they are taking these medications. So they're not as frequently used today. There's a whole class of what we would call antipsychotic medications. And there are the typical antipsychotics like Haldol, Prolixin, Thorazine, Melril. Again, these are very old medications, but they are very good medications in terms of helping reduce the psychosis and the voices that people hear when they're experiencing schizophrenia. Some of the newer ones are what we call atypical antipsychotics, and those are Risperdal, olanzapine, Geodon, Clozaril. These, again, are they're newer medications. They do have a bit fewer side effects than the old ones. But again, it's a kind of a trial and error with each individual, trying a medication, giving it some time to determine if it's going to have some effects on them, and if not, then trying another medication. The old typical antipsychotics, the Haldol, Prolixin, Thorazine, have some pretty significant side effects and can be very, really interfere with the patient's willingness to participate in treatment because the side effects are so uncomfortable. And with the newer ones, especially with the Clozaril, there's a risk of what's called agranulocytosis, and it's a blood disorder where the white blood cells crash. So people that are on Clozaril have to have blood draws every week before they can get their prescription filled for the next week. Then we have a group called the anti-anxiolytics, and these are typically the sedative medications, benzodiazepines, most familiar, the Valium, Ativan, Xanax, lorazepam, Klonopin. There's many more. And the barbiturates, the phenobarbital or Seconal. And these are used for to reduce anxiety, to increase sleep. They are highly addictive medications, highly abusable, and obviously if you take a lot of them, you can overdose and die. So they're medications that are used with more caution and should be monitored pretty regularly. And the other issue with these medications is that you will become tolerant to them. So if you take them, even if you take them as prescribed, eventually you will need more of the medication to get the same effect. And so the doctor will have to increase the dose. And so that's kind of a negative of using those kind of medications. Then we have mood stabilizers, and we typically see these prescribed with people who have bipolar disorder. And some of the familiars are lithium, Depakote, Abilify, valproic acid, Tegretol. And these just they kind of help the individual's mood stay at a more stable level versus the very Great Depression episodes or the very manic episodes. There's a whole group of medications that are used to support substance abuse recovery, and they're not something that you typically see, but there are people that are still prescribing Antabuse, which if you drink alcohol while you're taking Antabuse, you can become violently ill. There is Camprel and Naltrexone, which are thought to help reduce craving for alcohol. And then there is Suboxone and Methadone, which are to replace opiates like heroin or OxyContin, so that people can maintain functioning and hopefully become drug-free at one point. And then there's, the whole class of over-the-counter medications, vitamins, herbs, supplements. And believe it or not, some people can abuse these things. And so when I'm talking to clients, I always ask if they are taking on a regular basis anything that comes over the counter, any vitamins, herbs, and try to find out if they're taking them at least within the dose that's prescribed, because sometimes if they're taking too much, that can cause health problems for them, and it can interfere with their mood or their functioning. Unfortunately, with medication treatment, there are side effects. And as I said before, sometimes these side effects are quite unpleasant. With the old typical antipsychotics, the Haldol, the Prolixin, there's often a disorder that can develop called tardive dyskinesia. And this is kind of an involuntary, kind of what you would describe as a tic. People might have facial grimacing. They might have, their tongue may start to protrude from their mouth. They might have episodes where an arm or a hand may start to jerk involuntarily. And typically once these kind of symptoms start to develop, they don't go away, even if you stop the medication. So it's kind of, doctors are cautious in prescribing medications that can cause this. And unfortunately, when people develop schizophrenia, they typically develop it at a very young age, 19, 20, 21. And so to put them on such an antipsychotic that might render them with a lifetime disorder like tardive dyskinesia is, it kind of impacts on the hope for that person to maintain normal functioning. So the doctors will try to use some of the newer medications so that they can reduce those kind of unpleasant symptoms. Akathisia is another side effect that can be caused from some of these medications, and that's typically kind of a stiffness or a rigidness. You might see someone who, when they're standing, they kind of rock a little bit from side to side, or they have, they're fidgety, maybe that kind of leg movement, and this is just kind of a stiffness and I don't want to say agitation, but it's just kind of a way that they have to kind of continue to release some energy. Then there are what's called extrapyramidal symptoms, EPS, and these can be pretty significant when people are on antipsychotic medications, and they can end up having some very strong muscular stiffness, especially in the neck and the throat area, which can interrupt their breathing. So when people are prescribed Haldol or Prolixin, they are also prescribed an additional medication that helps reduce the probability that this kind of EPS symptom will happen. There is a syndrome called neuroleptic malignancy syndrome that can be caused by some of the antipsychotic medications, and this is typically shown, people have fever, stiffness, and typically is diagnosed by a psychiatrist because a lot of other physicians aren't real familiar with it. But it is something to kind of watch for and be aware of. And then there's what's called serotonin syndrome, and this can be caused by some of the antidepressant medications, especially if they're mixed with other medications that they don't interact well with. And serotonin syndrome can be described as someone having a lot of agitation, mood swings, pressure kind of building in their head, and so it's something, again, that you want to be aware of. When we talk about mental illness, we need to recognize that there is a tremendous stigma with the mentally ill. And most typically this occurs because people are fearful, they don't understand mental illness, they're confused by it, they hear a lot of things in the media about the mentally ill being dangerous. So it's really important for us as caregivers to recognize that these are people who have an illness no different than a relative who has diabetes or a neighbor who has heart disease. And so we need to recognize what we call people first, that they are the person first and not their diagnosis. And so we do that in how we approach people with mental illness, and we do that in how we talk about people with mental illness. For example, we might say, Joe is a person who has schizophrenia. He is not a schizophrenic. We try to describe them as their person first with whatever diagnosis that they have. Treatment for mental health issues can range from outpatient therapy to an intensive outpatient therapy, or sometimes it's referred to as an IOP or day treatment. And then there are inpatient treatments, both voluntary and involuntary. In Wisconsin, to get someone into treatment on an involuntary basis, there are a couple of different paths to follow. One is called an emergency detention, and I'll talk a little bit more about that later. Sometimes it's referred to as a chapter, or it's referred to as a 72-hour hold. And this is where law enforcement, along with a county crisis mental health worker, can decide if a person needs to be put on a hold because they are a danger to themselves or others. And then there is what's called a three-party petition, and that's where 3 adults can actually petition the court and ask a judge to detain an individual so that they can have an evaluation under that 72-hour hold to determine if they need to have some treatment against their will. Of course, there's medication therapy that we talked about, and then there is still today used ECT, electroconvulsive therapy, and this is where people are small seizures are induced by electric current to try to remap the way the brain is experiencing some of the chemistry that's happening. There are a lot of pictures in people's minds about how this was performed, and certainly we've seen different things in movies, but ECT is performed in a hospital setting. The person is given a sedative so they are not aware, and it's very well monitored, and then they remain in the hospital for several hours after the treatment to make sure that they don't have any adverse side effects. Typically, ECT is a last resort treatment for someone who's experiencing severe mental illness. In Wisconsin, we have Chapter 51, which is our state alcohol, drug abuse, developmental disability, and mental health act. And it's a very big statute that covers a lot of different things in terms of community treatment for all of these disorders. But basically, I wanted to just share with you that the premise of the statute is that communities provide a full range of services for people that have these disorders, and that the county, typically by counties, provide this service in the least restrictive, most appropriate way to meet the needs of the person within the level of funding that's available, whether that be county tax dollars, state tax dollars, federal dollars, and of course if people have insurance. And in order to protect personal liability, no person who can be treated adequately outside of a hospital, institution, or other inpatient facility may be involuntarily treated in such facility. So the law really promotes least restrictive, which means voluntary treatment whenever possible. And that is something that there are 2 camps on that. I mean, of course, there are people who say, oh, the mentally ill, they don't know what they're doing, they need to be forced into treatment so that they stay on their medication. And then there's the other camp that says, there are people with an illness, and many of us have disorders such as diabetes and we choose not to follow our diets, or we smoke. And so we have the right to choose our treatment, and so should people with mental illness. Just a point that with everything we see in the news, you know, there's a common thought that mentally ill people are dangerous. And the truth of the matter is that the vast majority of mentally ill people are no more dangerous than the general public. When we see these events in the news, like the shootings, the mass shootings, we need to keep in mind that most of these cases, either treatment was not available for the person or was not readily accessible to the person, or the person didn't follow the treatment. And so when treatment is not available, symptoms increase, which certainly can increase the risk that the person presents to the community. The good news is that treatment works, and proper supports are not always available, and there's a lot of barriers that exist, especially in terms of access to treatment, transportation, money, and then of course the compliance issue is a big concern, because we can, even in communities where we have a lot of treatment, the mentally ill may choose not to participate in that treatment. And that's where, in Wisconsin, the Chapter 51 law gives us an opportunity to evaluate whether someone is a danger to themselves or others, so that we can force them into treatment, so that some of these serious things that we've heard in the news don't happen. And there's some basic criteria that exist. So it's stating that the person is presenting a risk of physical harm to themselves or others. And this can be, you know, threats, attempts, threatening to kill themselves, threatening to harm someone else. So if they are viewed as a danger, that's one of the criteria. Oops, sorry about that. There also needs to be a substantial probability that the physical harm to other persons, again, it's the threat to other people, the threats of homicide or violent behavior. There's a probability of physical impairment or injury to the person because of their impaired judgment. And this is a big factor for me, because oftentimes when people have serious mental illness and they're not treated, they do things in the community, they you know, live kind of marginally, and there's a lot of loss of dignity by the way they live. And I feel very strongly that when someone's judgment is so impaired that they are you know, doing things in the community that are unsafe, it's important for us to try to intervene and get that person some help, at least so that their judgment improves enough that we can have a conversation with them about more long-term treatment. And then we have to be able to show that this illness or these symptoms are impacting their ability to maintain their basic needs for, you know, food, shelter, safety, and that unless adequate treatment is provided, serious physical injury could occur. When you're out working in the community as a caregiver, there's just some kind of helpful hints that I can share that might help you say, oh, you know what, I think this person might have a mental illness, and so maybe there's something I can do, or there's somewhere I can refer them, or there's something extra that I need to be aware of. So one of the things that I suggest is be familiar with some of the names of the treatment providers or psychiatrists in the area that you work. And this will help you recognize, for instance, if someone tells you that they're on a medication, or they show you a prescription bottle and it has a doctor's name on it, you might be able to say, oh, I know, that's a psychiatrist that works at this facility. And so that kind of clues you in that this person may have a mental health issue. And also, it's helpful to at least know a couple of treatment programs or a crisis program that you can call and consult with. And just say, you know, I'm working with this person. Sometimes they won't be able to share names with you, but you can just say, they're demonstrating these kind of symptoms, and I'm not sure if there's anything else I can do, or I can refer them to. So just having those kind of opportunities to be able to share a little bit and find out a little bit more about the people that you're working with. Watch for things like pressured speech, difficulty with personal space. Sometimes the mentally ill don't like people to be very close to them. They sometimes are in your space and they don't realize. It doesn't seem like it makes them uncomfortable at all. Oftentimes they have very tangential thoughts or speech. You ask them a question and they start to answer it properly, and then all of a sudden they're off on some other topic that is completely not related to what your question was. Oftentimes there are some irrational beliefs. We talked a little bit about that before, the delusions. There are obsessions, compulsions, and there's a lack of awareness of reality. Watch for eye contact and unique behaviors. Sometimes you can be talking to someone and it looks like they're staring right through you. That may be a concern to ask them, if they're hearing voices or if they're being distracted by something. Oftentimes, too, you can kind of tell if someone's hearing voices. You can tell that they're paying more attention to something internally than they are to you or what's going on around them. Again, the facial tics related to the medication side effects might be a clue that this person has a mental illness or struggling with some medication issues. And when we talked about the impact of trauma, one of the things that we try to recognize is instead of looking at someone who's having these problems and saying, what's wrong with her, consider what happened to her and try to take that approach. Sometimes it's a much easier way of dealing with that person and trying to engage with them versus the what's wrong with you, why aren't you following your treatment. Ways that you can be helpful. Pay close attention to the content and the pace of their conversation. Don't challenge delusions or argue that things are not real. This is not going to get you anywhere. I'll give you an example. We had a woman that was in one of our care facilities, and she was convinced that there were people who were going to drive by the building and shoot up the building. And one of the staff were very clever, and they took her into a back room and they just said, you know what, this is a safety wall. And so when we sit back here, we're perfectly safe no matter what happens out there. And she was able to accept that explanation. It wasn't necessarily a lie. We didn't challenge her that, you're crazy, there's nobody going to drive by and shoot us, or nobody implanted anything in your head. So by doing that, you're just going to set up barriers, and they're not going to trust you. They're not going to want to engage in treatment. So if you kind of just go along with them and talk about how frightening that must be. It's awful that you're afraid all the time that someone's going to come by and shoot you. Let's go in this back area where we can be safe, and let's talk a little bit more about that. You just get a lot more engagement with the client, and you're not going to set it up for them to not trust you. Be kind and help the individual feel safe. That's a very important thing. Oftentimes people with mental illness have paranoid thoughts. They have the voices that are telling them they're no good or they should kill themselves. And so letting them know that they're safe and that you're with them and you're going to try to help them in any way possible can oftentimes help them stay calm and feel safe and work with you. Do not be afraid to ask directly about medications that they might be taking, treatment programs that they've been involved with, or symptoms that they're experiencing. It's not uncommon for us in our work to say to someone, have you ever heard voices that you think aren't, the rest of us don't hear? And if they say yes, then a follow-up question might be, well, what do the voices say to you? What kind of things do you hear when they're talking to you? Ask directly about suicidal thoughts, attempts, or plans, and don't be afraid that you're going to plant an idea in their mind. We need to ask this directly because oftentimes if people are experiencing these thoughts, they feel very relieved when someone has asked them and not freaked out about it. If you can ask them and say, you know what, that's terrible that you're feeling that way, I'm going to do whatever I can to help you stay safe, that's a big relief to someone who's been carrying the burden of thinking about killing themselves. And this is one of my favorite frames for speaking with the mentally ill, is to come from a stance of benevolent curiosity. Just, looking at that person with compassion and care and saying, it must be really frightening that you think the government implanted listening devices in your head. Why don't you tell me a little bit more about that? Why do you think they would want to do that? And sometimes by just having that kind of genuine, curious, non-judgmental stance, you can get a lot of information and a lot of connection with an individual. The next couple slides are resources that are extremely helpful and provide a lot of information if you have questions or just want to learn more about mental health issues, suicide. NAMI is the National Alliance on Mental Illness. It's a great resource for families. They do a lot of family education work. Mental Health America is another great organization, the National Institute of Health. Prevent Suicide Wisconsin is a statewide organization that is trying to promote the message of suicide prevention. Again, these will all be part of the packet that Rachel will provide for you, so you'll have access to these resources. And then I did add a couple here at the end for Upper Michigan, the behavioral health in Marquette. There's a Pathways that has a couple of different connections and a crisis connection in this area, which is really helpful. And then there's some other opportunities in the Upper Peninsula Association of Rural Health Services. So hopefully some of these resources can be helpful for you to get additional information, find out more about what kind of resources are available, what kind of funding is required for clients to receive services there, etc. And now I would ask if you have any questions.
We had one that got sent in while you were presenting, and they just wanted to know the name of the physician's book, or PDR, again.
It's called the Physician's Desk Reference.
All right. We'll kind of hang out for another minute or so. If anyone has questions, you can raise your hand and we can unmute you if you have microphone capabilities, or you can type those into the box. Again, I will email everything to you probably next week sometime, and then we'll be back for our next webinar on September 12th, and that will be with Robin Lickle on vicarious traumatization and self-care. So,
excellent, yeah.
Yeah, which piggybacks very well on this topic. So if anyone wants to get those emails sent directly to you, there will be a place to fill that out on the email. Otherwise, you'll hopefully be able to continue getting those forwarded to you from your social services directors and whatnot. So, all right. Doesn't look like we have any questions. So thank you so much, Deb.
All right. Thank you.